Hello and welcome to Processes and Documentation in the Psychiatry module. Among the topics that will be covered here are admissions, case presentation, progress reviews, handovers, orders and requests, referrals, as well as discharges. The first section of processes and documentation which you will need to learn is the admission clerking. This will be one of the core tasks required from you. Having good documentation skills and clerkship skills are going to be an advantage throughout your training. Patients from the psychiatric divisions are admitted either from the emergency department or outpatient psychiatric clinic. Once the patient is reviewed and admission plans are ordered by the attending psychiatric team, nurses from the emergency department clinic or other wards will arrange a bed by liaising with the ward nurses. So as a house officer, you play a role of clerking the patients. However, at most times, you'll be doing this simultaneously with your medical officers. You'd be in charge of ordering investigations, which include lab works and imaging studies. Basically, you will need to ensure all orders are carried out accordingly as well. Should you face any hiccups in performing them, always remember to seek help from senior colleagues or from your team members. As for the psychiatric patients who would be admitted to the ward, clerking is not usually repeated by you or your doctors when they come up to the wards. We try to avoid doing repetitive clerking with these patients to avoid any kind of further stress to the patient, as some may be already in distress. Therefore, history and mental state exams are usually done at the emergency department upon referral, as well as the psychiatric outpatient clinic itself with your medical officers. However, once the patient is admitted to the ward, you can review the clerking, which was done earlier, and have an idea of the case that you might be dealing with to be able to revisit the history and fill up any more information left later. Review of the observation chart to ensure the vital signs are charted and within acceptable ranges. If the vital parameters are abnormal or if the patient is in any form of distress, alert your medical officer or specialist immediately. Now, the take-home message here would be if you're done with your clerking and physical examinations, you will then need to learn how to present your cases to the medical officer or the specialist who comes to review. Write or type out every point or plans given by the medical officer or specialist. Try not to take risk by just remembering verbal orders. Once the patient is seen with a medical officer or a psychiatrist, always write their respective names on your clerkings, such as seen with Dr. A, discussed with Dr. B, and attended with Dr. C and Dr. E. Documentations are the utmost important, therefore pay attention to every single detail written or typed. So let's look at what a case presentation is. A case presentation is a formal communication between healthcare professionals regarding a patient's clinical information. It is the job of the presenter to share the pertinent facts of the patient's case with the other members of the medical care team and establish a clear diagnosis and treatment plan. So in your housemanship training, you'll be delivering many case presentations as your communication with your superiors actually begin here. You'll be evaluated on the point of history of presenting illness, examination technique and findings, clinical judgment, and a reasonable plan. Let's begin with the opener. So you should begin every oral presentation with a brief one-liner that contains the patient's name, age, relevant past medical history, and chief complaint. Remember that the chief complaint is the reason that the patient sought medical care in his or her own words when they are able to. Otherwise, it would be from their parents or caretakers. Then comes the history of presenting illness. Elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. Next would be past psychiatric history. The patient's underlying psychiatric diagnosed history has to be explored. The medications that he or she has been on or also state the compliance to the medications. Mention follow-ups of hospitals as well. Then comes the past medical and surgical history, where you may want to get more information about the patient's underlying medical condition or if there happens to be any surgery done before. Any history of allergies, that would be important to find out as well. Family history, where it should give you a good indication of the person's family relationship. Find out which members of the family they feel close to and why. Equally, reasons for discord within the family should be explored. So bear in mind social, psychological, and genetic risk factors for mental illness, and remember to ask about family psychiatric history. Next would be the social and development history. State regarding family support and factors that may have contributed to patient's mental stress factors. You may also inquire regarding the patient's birth and early life, school and qualifications, higher or further education, employment, psychosexual history, forensic history, and substance abuse. Next would be the physical exams, which is an important component here. And once you have finished reporting the patient's history, you should transition into the physical exams. You should begin with reporting the patient's vital signs. The mental state examination. The mental state exam is an important clinical skill. And what is important is that you develop a framework in the mind so that you are aware of gaps that still need to be filled. It can help to start with a list written down with space to write in the relevant sections. Now, the areas that you will need to look into would be appearance and behavior, the patient's speech, the patient's mood, which is often described in terms of elevated or depressed mood, the thought, where the thought content may be revealed by what the person says, but you will also need to ask questions about their thoughts. Obsessional thoughts, anxious thoughts, overvalued thoughts, ideas all need to be considered as they may not be volunteered by the patient. Next would be perception. So at the beginning of the perception section, a second voice is heard. Think about your reaction to this voice. Was it disconcerting at all? Next would be delusions, which is having been described as an ununderstandable, and yet we need to try to understand what they mean to our patient. Cognition, insight, and lastly, looking at the results of the lab tests, imaging, and other diagnostics once your mental state exam is over. You should conclude your presentation with the assessment and the plan in the end. Now let's take a look at an example of a case scenario. In the slides before, we have shown you the flow of the case presentations. Now, let's begin with this scenario, which is about a young adult who was brought in by his father to the emergency department. This patient is 30 years old. He's brought in by his father as he was banging his head on the wall at home and saying he is asking me to kill myself. The father claims the son's symptoms of paranoia started 2 weeks ago, where the son's manager reached out and informed that he noticed some behavioral change. Patient was caught attacking another colleague at work, and also he was walking on the hallway as he was cursing out inappropriate words. Father claims he noticed his son tickling himself and laughing inappropriately. There's a history of stimulant use, which is methamphetamine, at the age of 25 years old. However, there's no observed change in sleep patterns. Patient has been diagnosed with schizophrenia 2 years ago and has been on medications. The patient's symptoms at the onset of his illness would be auditory hallucinations, suspiciousness, and ideas of reference and hostility. His symptoms were attenuated by the use of neuroleptics and supportive therapy. However, he is also not compliant to his medications and follow-up. As for the family psychiatric history, it's unremarkable, with a past medical history of schizophrenia as well. And for the social and development history, the patient is the second son of 3 siblings. He lives with his father. His parents have been separated since the age of 18 years old. And he completed secondary school, obtained many jobs. However, he refused to speak about it. His siblings have moved away but have contact periodically. Next, we will move on to the examination findings. And here you may want to inform your team that the patient has vital signs, measuring blood pressure off with a heart rate, and how is the nature of the pulse volume as well as the perfusion. Here the general appearance is important, where you will also consider mentioning the vital organs examination, which is the cardiovascular system, the respiratory system, anything abnormal within the abdomen, and most importantly, not forgetting the neurological examination, which is to see whether is the patient's higher cognitive function as well as his neurological functions are intact, symmetrical, with unremarkable gross movement disorder. When the patient is aggressive, do not try to perform any physical exams until your medical officer or the psychiatrist is around. Also take note that those patients who has an underlying history of psychiatric conditions may not require physical exams except vital signs unless indicated. So now you have successfully learned how to present a case based on the history that's been taken, as well pairing it up with the examination findings. Now, let's move on to progress reviews. All patients in the ward will require a progress review. This means you will need to review patients according to whom you're assigned to. You will need to know the progress and the current issues of these patients from the day before till the morning you see them. You're able to speak to the patients and ask them how they feel. Examinations for psychiatric patients may not be necessary unless there's a significant complaint from the patient or something you have observed on him or her. There's some tips to speed up your understanding of the case before you begin your review. You want to ask yourself, why is the patient in the ward? How many days is the patient in so far? How is the patient doing today? What have we done in terms of tests and treatment? What are the future plans or advanced plans? And finally, what are the impending test results for today? Reviews are done in the mornings and maybe before you leave the hospital unless an emergency sets in. Once you have done your reviews, present your review findings to your medical officer who will be doing his or her part of the review as well, and there might be changes or additions to your review. Document promptly so that nurses will be able to carry out their part of the plan as well. The AM review is usually from 7 a.m. to 9 a.m. And between 9 a.m. to 2 p.m., you will have the time to carry out your ward work. PM reviews begin from 2 p.m. to 4 p.m., and on-call reviews will start at 8 p.m. onwards. Next, let's take a look at handovers. A handover occurs when a house officer hands over the responsibility of care for a patient to another house officer, for example, at the end of his or her shift. On average, handovers occur 3 times a day for each patient. Handover occurs at every level of care from the consultants, specialists, and even amongst nurses once their shift ends. And they are very important to ensure a smooth transition, as you will find much less disruption of team workflows and productivity rates. So, what is the role of the house officer? As a house officer, you will need to follow a well-devised format of handover to ensure pertinent information regarding the patient is not missed and to avoid wrong information passed over. There should be information regarding the past events, present plans, and future events. When service from another department is required, a request is made. House officers are assigned to make requests following the plans in their daily reviews. So let's take a look at how does a request work. Identify what is the test that is to be requested. Identify the departments involved. Identify the officer in charge of taking the request from the receiving department. Try not to randomly call medical officers from other departments when you are not sure. Outline the purpose of the request, urgency for the test to be done, how the test will be able to aid the diagnosis and management of the patient. Identify the criteria needed for the requested test. And finally, identify the documents that are required to be filled. So you begin with completing the request form for the test, followed by calling or meeting the medical officer in charge of receiving the request. Once granted, informing the nurse on the plan to transport the patient over to the location of the test or collect specimens for the test requested, and finally, documenting the trail as to who granted the test, when the test is planned for, and preparation steps for the patient. If your request is not granted, take down the pointers to why it was rejected and convey the information to your medical officer. Your medical officer will be responsible to troubleshoot the situation. Now, these are examples of tests that require request of verbal communication or approval, and these are radiographs reporting, early and urgent ultrasounds, CT scans, MRIs, group safe and hold and group cross-match code, urgent full blood picture or peripheral blood film, as well as an echocardiogram. And as for the tests that do not require verbal requests, they are basic routine blood tests, radiographs, and non-controlled medications. Now let's take a look at how do referrals work. Referrals are made to other departments for their management or input or suggestions, or if their skill sets are required in the management of a patient. So what is the role of the house officer here? It is importantly to identify the purpose of the referral, to identify the departments involved, to identify the medical officer in charge of accepting the referrals from the receiving department, to call the medical officer in charge, and to document the trail as to time at which the referral was being made, the indication, and the medical officer who accepted the referral. Let's take a look at an example of a referral from the psychiatric to the medical department. Of course, you begin with confidently and clearly introducing yourself. So, for example, you may say, "Good morning, Dr. Charles. I'm Dr. Thomas, a house officer from the psychiatric department." Then you proceed on by stating the patient's details as well as the reason for the referral. So, an example would be, "I would like to refer a patient for uncontrolled hypertension. This is a 33-year-old man with an underlying history of hypertension but was non-compliant to his medications for many years. He has been admitted to us for the last 2 days now. However, he has been taking his medication now as served by the medical officer here. His medication is currently amlodipine tablets, 10 milligrams once daily. His blood pressure ranges between," you may state the range, and you've also got the latest investigations ready, and they are renal function tests as well as the liver function tests, which are both normal. So you may then conclude by requesting a review in order to manage this patient's hypertension. So also importantly, inform the reason for diagnosis of admission to the psychiatric ward. He is currently admitted under psychiatry for severe depression. Sometimes you may not need to present the whole initial clucking regarding the psychiatric related conditions unless it is asked about. Now, finally, we come to the discharges. A discharge summary plays a crucial role in keeping patients safe after leaving a hospital. Hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. Often, the discharge summary is the only form of communication that accompanies the patient to the next setting of care. High-quality discharge summaries are generally thought to be essential for promoting patient safety during transitions between care settings, particularly during the initial post-hospital period. So what are the roles of a house officer? House officers are responsible for formulating a complete discharge summary and carrying out discharge work as stipulated in the summary. There are 6 main components of a discharge summary: reason for hospitalization, the significant findings, procedures and treatments provided, patient's discharge condition, patient and family instructions, as well as the attending physician's signature. And now, what do you need to do prior to allowing patients back home? You would need to make sure patient's general condition is well and all plans are given by the specialist or the medical officers are carried out. Remember to order discharge medications early so patients will receive them on time. This ensures a smoother process flow. Should there be a need for medical certificate for school or work to be issued, inform your medical officer or specialist in charge to fill the certificate before the patient leaves, as it will be included in their discharge docket. If the patient has been co-managed with other specialties, communicating the discharge plan to them will be necessary to ensure there are no clashing plans or appointments. We have come to the end of this session. Thank you for your time.